Good day, folks. Alfie Venta here, once again at Venta Pain Relief Clinic and VPRC.ca. I'm hoping you're having a great day. Welcome to part two of rowing pains. This is our soft tissue case study. This is the answers and discussion portion of this. So I want to thank you if you participated in part one, where I'd ask you to write some notes down. So just to let you know, these cases are not just cases for massage therapists. They're actually designed so that a physiotherapist or a chiropractor or whatever healthcare professional that has a specialization or a focus on the fascia and the muscles, they can actually use this. And what I mean by that is that you have been given certain techniques to work with the soft tissues, and it's applicable to this case. So just because you're not a massage therapist doesn't necessarily mean that you won't be able to use this case, because you do have tools that have been given to you from your training. So let's get on to the soft tissue case study, Rowing Pains, Part 2. So as a review, you meet your new patient, client, and you introduce yourself. You notice that she tends to lean, put more weight on her right leg relative to the left. And I'm sure many of us have seen this where they're kind of leaning to one side. Maybe they have their foot turned out to the externally. She states to you that for a month now she has been noticing right-sided lower back pain and tightness. Hip and right-sided shoulder pain and tightness also. She's also a competitive dragon boat racer. She oars on the right side. So she's constantly doing this action here. The shoulder pain is located on the anterior aspect of the shoulder, and so I've got to add that it's fairly deep in there when you palpate, and we'll talk about that in the key observations. At times, she feels that when she raises her right arm, that there seems to be a bit of resistance versus the left. It's not that significant, but it's noticeable. On her health history, you notice that she has a 1-year-old child. You ask her what side she tends to carry her child. She states on the right side, so she's kind of carrying it like this, the shoulder in this position here. So that's a habit that she does along with her rowing. Now we're going to talk about the key observations, but before I go into the key observations, if you like our content, please like, share, subscribe. Pass this on to those that you feel this might be helpful for. If you're on YouTube, please hit that notification bell. I want to add also, if you're an instructor and you feel this might be helpful for your students, I encourage you to pass it on. We want to thank you way in advance. So now let's talk about the key observations. The right shoulder is significantly more internally rotated relative to the opposite side. There is tenderness upon palpation deep into the center of the anterior deltoid of the right side. So when you actually palpate into the area there around the bicipital groove, there's a lot of tenderness. The right latissimus dorsi upon observation seems more developed than the opposite side. Palpation of the belly of the muscle on the rib cage is tender and in certain specific locations seems to elicit referral pain down the right arm and in a diffuse radius around the pinpointed area. And I'm going to show you a schematic of that in a second. It is observed that the right-sided hip and pelvis seem to be more hiked relative to the left when patient is observed in a prone position. So in other words, it kind of looks like this. So if you're looking at the one side looks like it's a little higher than the other. You could also palpate this too. Like if you're using your palm, you may notice that it's kind of in an angle. The pelvis, that is. Using a pincer grip, you access the thoracolumbar fascia from between the 12th rib and the pelvis. You notice how tight it is, and the patient client states that there is tenderness. So this is fairly hard, particularly if that area is very tight. So the pincer grip kind of looks like this. You kind of grasp into the area and you kind of palpate and kind of try to move the tissues around. And you notice how tight it is. It also seems that there is less spacing between the 12th rib and pelvis as compared to the unaffected side. So when I say less spacing, you notice that there's less of a gap. It seems like there's less of a gap between the 12th rib and the pelvis relative to the opposite side. So, you're going to palpate the unaffected side and then the affected side, and you do notice a bit more of a gap on the opposite side, on the unaffected side, relative to the side that's problematic. On palpation, the fascia is very tight, located on the right side of the inferolateral aspect of the rib cage to the iliac crest and towards the lumbar spine. I also have a picture for that right there. So this is where the area that I'm talking about. I've circled it with that black marker where the lat is. So that's the location. These are the critical thinking questions that I had asked in part 1. List 4 muscles that you would attempt to release. What are the structures might you want to address on top of the 4 muscles? Of the 4, what muscle is potentially causing the most havoc? Explain your reasoning. Explain the mechanics behind why you think your patient client became symptomatic. So question number 1. List 4 muscles that you would attempt to release. So these are the 4. This is in no particular order. Latissimus dorsi, gluteus maximus, quadratus lumborum, and gluteus medius. What other structures might you want to address on top of the 4 muscles? So this is a very important point here, and I will show you a picture as to the reasoning behind this. The thoracolumbar fascia. That is one of the structures you really want to address. The fascia is potentially tight, also causing pain, discomfort, and tightness. So when you're actually palpating around the area, when you're doing maybe a skin roll, when you're doing your fascial techniques, you notice that it's very, very immobile. The structure links the upper body and lower body together. The lats and gluteus maximus attached to the structure. If one of these 2 muscles are extremely tight, it can impact the other. Releasing one may decrease tightness of the other. Now, I'm going to tell you from a clinical standpoint over the years, what I've noticed is that when I'm working into the attachment of the lat, if it's very, very tender, if I'm seeing this kind of this type of case with a particular person, what I will do is I'll target the front of the shoulder there, trying to get into the attachment of the lat. Wait till the tenderness fades, and what I've noticed is basically the area on the thoracolumbar fascia and the lumbar spine tends to release. So you'll notice like it softens up. It softens up a lot better than actually direct work on the lower back and the thoracolumbar fascia. Just a little bit of a tip for you guys. So here is the thoracolumbar fascia. This is a schematic by Dr. David J. McGee from Orthopedic Physical Assessment, 4th edition. This is a textbook that you guys probably have. So you'll notice that that white area there, this is the thoracolumbar fascia, and this is the lat. You see here, and this is the glute max. So you notice that this is the center point, kind of like the sandwich point, where both muscles attach. So what you potentially can see is that you might get more pulling if something's really tight on one side, causing an impact lower down or higher up. So remember, with the thoracolumbar fascia, it actually connects the upper body and the lower body. The upper body via the latissimus dorsi into the attachment at the shoulder there, and of course the gluteus maximus. It connects the lower body. And just to add on to this, like the gluteus maximus also blends into the iliotibial band, so it goes down the leg, past the knee on the lateral side. Of the 4, what muscle is potentially causing the most havoc? Explain your reasoning. And you may have gotten the clues already, but just to emphasize, these are the clues. The latissimus dorsi is the muscle that's causing most of the havoc. So the clues are the activities in particular, the rowing on the one side of her body, also carrying her child on the one side with the hiked hip. So that would shorten the muscle even more by having your shoulder rotated like as such, and having your hip hiked up. The pain at the front of the shoulder, the internally rotated shoulder also, because remember the lats also rotate the shoulders internally. The lat unaffected side is more developed. That's a big clue right there to tell you that maybe there's a strong possibility that it's the lat that's causing a lot of these issues. Further with the clues, the referral pain down the arm when palpating very specific areas of the belly of the muscle. I've got a picture after this slide here. Some difficulty raising the arm, although I mentioned that in the case that it wasn't that significant, but it is noticeable. Remember, this person's raising their arm. What the lat does is it does adduction and it does extension. So it does the opposite of this kind of motion here. And if it's really tight, it can pull down on the humerus so that there's a bit more difficulty when you're doing this action here. So this is my own schematic of the lat trigger point. This is on the posterior side. There's also some points that you'll notice in other trigger point charts that actually that the lat refers to the front side of the rib cage. So here You have the lat kind of diffusely like radiating around this area here where the muscle is. And also, it can travel down the arm towards more the pinky side on the dorsal aspect of the forearm on the medial side. So that's the lat trigger point. So if somebody comes in and they're telling you that they got this referral pain down the arm and it feels kind of like tender around the mid back or so, and you notice the internally rotated shoulder, and they're giving you all these different clues that point to the lat, this is something to sort of be aware of in terms of the trigger point referral pattern. So, actually going back, I just want to go back to the thoracolumbar fascia for a second for question number 2. I had asked other structures that you might want to release or work on. You might want to add in gluteus medius because that person stands on one leg. More on the one leg. So the gluteus medius stabilizes the pelvis when the person's planted. The other one too is you want to look potentially at the internal rotators of the shoulder, pectoralis major, maybe subscapular. So those are a few things that you can also add, but the thoracolumbar fascia is definitely an area that you want to go after in terms of the treatment. So explain the mechanics behind why you think your patient client became symptomatic. Basically, overuse of the latissimus dorsi via the rowing activities plus the carrying posture from carrying her child have over time caused her symptoms. Also, her tendency to lean on her right leg have caused issues with the glute and the hip. So, like as I mentioned in the case, this person kind of leans to one side. It's a habitual thing. And over time, it can cause the hip and the glute to become tight and tender. So there you go, folks. Now, I want to know what your theory is as to how you came about your conclusion, because I'm very, very curious to see what your thinking process is. So if you want to share, go right ahead. Just comment below. I'm curious to hear your answers and also just the thought process as to how you got to that point. It's great for discussion. We want to thank you again for watching these case studies. This is really fun for me. I love passing on what I know, what I've learned over the years, and hopefully you can use it in your practice. And hopefully you have used some of these things that I've kind of mentioned, and maybe it's helped. And if it has, again, comment below. You can also, please, if you don't mind, please like, share, subscribe, and pass this on to those that you feel this might be helpful for. And again, hit that notification bell if you are on YouTube. Also, you can follow us on our social media and visit our website. Well, we have 2 websites. We have ventepainrelief.com, which is more kind of like for patients, for the general public, and we talk about different conditions and massage therapy, deep tissue massage, rehab, so on and so forth. And we have vprc.ca, which is our pain relief fitness site, where we give tips in terms of managing your pain on your own, and also helping yourself in terms of managing pain while you are trying to get fit. Again, my name is Alfie Vente of Vente Pain Relief Clinic, and keep an eye on our future case studies. We're going to have hopefully one case every week, and we hope to see you soon. Have a great day and take care.